Hello everyone, Dipen Patel. I'm a clinical research fellow at the Department of Psychosis Studies at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and I'm also a specialist trainee in general adult psychiatry at South London and Maudsley NHS Foundation Trust. I'm going to be talking to you today about my project entitled The Implementation of an Electronic Clinical Decision Support System for the Early Recognition and Management of Diabetes and Dysglycaemia in Secondary Mental Health Care. And I'll be focusing specifically on the protocol for a pilot 2-arm randomized controlled cluster trial. So today I'll talk through the background to this project. I'll talk through some of the development work that has gone into the electronic decision support system tool. I'll talk through the trial protocol and also discuss the planned evaluation for the study. So just a brief background, people with serious mental illnesses such as schizophrenia, schizoaffective disorder and bipolar affective disorder do have significantly reduced life expectancy compared to age-matched counterparts, and that's largely attributable to physical health causes. And we know, for example, that SMI patients have significantly more cardiometabolic risk factors like elevated blood pressure, elevated blood sugars, etc. Locally in Southeast London, rates of diabetes in established psychotic illness are approximately 20%, with a further 30% having elevated blood sugars. And that's reflected really in a higher prevalence of diabetes, which is 2 to 3 times higher in patients with a schizophrenia diagnosis. There's therefore a need for research into more targeted and clinically informed interventions that improve the standard of physical healthcare screening and interventions which are offered to this group across both primary and secondary healthcare settings. I think the adoption of novel digital technologies, I think it presents quite a unique opportunity here, but as with any new intervention, it does require evidence of acceptability, feasibility, and consideration of its implementation in order to be scaled up on a wider scale. Clinical decision support systems encompass quite a broad array of different tools, alerting systems, reminder systems, and intelligent information displays. The literature defines an electronic clinical decision support system as any electronic information system based on a software algorithm which is designed to aid directly in clinical decision making, in which characteristics of individual patients are used to generate patient-specific assessments or recommendations, and these are then presented to clinicians for their consideration. Important just to note that systems like these do not take over the decision-making process, but it's ultimately down to the clinician to decide whether to act on those alerts or not. There has been some work looking at electronic decision support systems, particularly in acute physical healthcare settings over the last decade or two. And early findings are largely positive, but there remains under research into this area thus far. So the digital tool that we'll be using in this study is called CogStack. It's a software platform which is developed jointly by the NIHR Maudsley BRC and the Precision Health Informatics Data Lab. It's an open source information retrieval and extraction system, and it has the unique capability to offer almost real-time searching of any clinical data source. So in this case, it's the electronic health record via NLP, natural language processing, and it can then prompt based on algorithms which we provide to it. And this system has been used initially at King's College Hospital and has shown evidence of early potential to be of use to clinicians for monitoring, intervention, and follow-up purposes. We firstly use an MDT to develop an updated clinical algorithm, which was based on local and national guidelines, and that was approved by the South London and Maudsley NHS Foundation Trust as standard of care. We then used a digital algorithm which essentially mirrored that clinical algorithm to identify specific points where decision support could be applied, largely driven by glycated hemoglobin results, blood test results. So that's HbA1c, which is a gold standard really for not only diagnosing diabetes, but also monitoring blood sugar control in diabetes patients. And we then built on the CogStack platform a automated alerting system, which would then send alerts out to clinicians to notify them of patients regarding evidence-based patient-specific interventions. Type 2 diabetes lends itself quite nicely to a system like this because the thresholds define really the interventions that are recommended, and therefore it's almost a traffic light type system. So this slide hopefully helps to visualize how the system will work. Essentially, as I said, it's driven by HbA1c results on the electronic health record or absence of, in case they haven't been done. COGSAC recognizes that. The algorithm then kicks in, and then alerts are sent out to clinicians. In this case, it will be via two means. One is directly to the electronic health record, where it will then be viewed by a clinician, and we'll also be using email alerts initially for the pilot study. And as I said, sent only to clinicians. This is just a screenshot of the electronic alerting system. So there'll be a little notification in the top corner when a user logs in. They can click into that. It brings them to the alert page. They'll then get a diabetes notification. So in this case, a yellow flag saying that their blood test hasn't been done within 4 days of admission. The clinician can click into that, and they'll be provided with more useful, relevant information. In this case, historical blood test results. So the system will provide digital alerts really to prompt guideline-based recommendations for clinician-led monitoring and management for dysglycemia and diabetes. And that's tailored to the individual patient based on blood results on the system. So that could be reminders for monitoring where it hasn't been done, providing guidance on whether blood results meet the criteria for diagnosing diabetes, etc. Prompting guideline-based psychosocial interventions, such as referrals to dietetics, smoking cessation, prompting pharmacological interventions, so for example, initiating a medication like metformin, and we can also provide links, signposting to the guidelines and medicines information on our Trust Intranet website. So I'll now move on to the study itself. The primary objective really is to establish the feasibility and acceptability to clinicians of this electronic system, which comprises an alerting and clinical decision support system for dysglycemia and diabetes management in a secondary mental health care inpatient setting. Secondary objectives here are to assess whether that system leads to changes in screening, follow-up testing rates, and clinician-led evidence-based interventions for dysglycemia and diabetes. We'll conduct a process evaluation really to assess barriers, facilitators, unintended consequences, etc., of implementing that system onto the wards. And data gathered from the study can then allow us to refine the system, hopefully address any potential problems that arise in regards to successful implementation. And we can then move on to a larger and more definitive effectiveness trial. So the study design, this will be a 2-arm randomized controlled cluster trial, which we'll conduct in an inpatient ward setting at South London and Maudsley NHS Foundation Trust. Wards will be the unit of recruitment, and we'll assign them to either have access to the system or it will be a control group. And we aim to recruit 4 wards in total and run the system for 4 months. And we'll be recruiting clinician end users, so medics, senior nurses, ward pharmacists, etc. In terms of the outcomes, as this is a feasibility study, the primary outcome here relates to acceptability to clinicians and feasibility of the system of running the trial. Secondary outcomes relate to process of care measures. I'll come to that shortly, but it essentially screening rates for diabetes, looking at changes to prescribing of medication, referral rates for lifestyle change interventions like smoking cessation. We'll adopt a mixed methods approach to establish these outcomes. So that will include things like pre and post study surveys and individual interviews with the participating clinicians. And finally, we'll conduct an evaluation of the implementation of the system. And we'll be looking at various implementation outcomes based on established frameworks. So looking at our primary outcomes, I think we're quite keen to explore the clinician experiences of the system, the impacts on their workload, barriers facilitators to using it, impacts on time, whether clinicians feel it's effective, and whether they'd continue to use the system if it was available. Here we have various process of care outcomes that we'll be measuring, HbA1c testing rates, documentation in the notes regarding diabetes diagnoses, delivery of pharmacological interventions, so for example, initiation of diabetes medication, and we'll be looking at communication, so follow-up to the GP or the community mental health team once a patient is discharged. A group in Norway have quite recently published something called the Guides Checklist. So this is a implementation framework which is designed to help professionals in implementing computerized decision support. So it's particularly relevant to this study here. These are various implementation outcomes that we will be looking at. And as I said, the aim really is to use all of this rich data to then inform future system redesign as we move forward to a larger trial with a view to upscaling this on a wider scale. So in conclusion, electronic clinical decision support systems have the potential to improve clinician-led management of diabetes and dysglycemia in inpatient mental health settings. If we do find evidence of feasibility and acceptability in this study, then in combination with the results of the implementation evaluation, we can refine the system, address any potential problems with future successful implementation, and then move forward to a larger and more definitive effectiveness trial to assess the impact on clinical outcomes and hopefully scale up this tool and apply it to other conditions aside from diabetes and hopefully expand to wider settings too. There are my references. Also just wanted to acknowledge, as you can imagine, there's quite a wide MDT involved in this study, and in particular my academic supervisors, Prof. Cochrane and Dobson at King's College London. Also just want to acknowledge my funding. Thank you very much for listening. I'll now hand back to our chair. Thank you.